Assalamualaikum warahmatullahi wabarakatuh to Dr. Roseliza Murni binti Rahman. My name is Kamalia binti Kamisan A164794. So today me and my friend from group 10, which is Atiqah, Izzati binti Zainal and Izzani binti Zaki, will be present about Encopresis and attention deficit hyperactivity disorder. So for the first article is parents administer behavior therapy for inappropriate urination and Encopresis, a case study. For the introduction, Encopresis is the repeated passage of feces in inappropriate places by a child. It is often the result of chronic constipation, which over time results in the leakage of stool. Typically, this behavior is involuntary. Children with encopresis often feel ashamed and may seek to avoid entering situations where they could feel embraced. Encopresis can be diagnosed according to DSM-5 and has two different types of encopresis, which is a primer and secondary. For the primer, is the control of the removal of the stool is never achieved by the child, and for the secondary, encopresis occurs after the child has reached control of the removal of the stool, and this type is first detected around 4 to 8 years old. The subject is a 6-year-old boy with a 2.5-year history of incontinence of urine and secondary reactive encopresis. The boy had been diagnosed functional megacolon by the pediatricians, and the program made by pediatricians for him will never succeed. The psychiatrist diagnosed him as depressed child with encopresis and defective object relationship. So the psychiatrist recommended long-term psychotherapy to deal with the encopresis. For the methodology, the first phase of this program involved establishing a baseline for daily bedwetting, pants wetting, soiling of pants, and appropriate use of the toilet. The reinforcer agreed with the parents, and the psychiatrist is Murni. The program started late during the baseline period, right after one event happened that the boy asked his father for money, and then his father said, if you try to go kaka, then I'll give you a quarter of money. Then the boy succeed to do that, and then after that, the treatment phase started. The instruction for the program given to the boy and the parents, the boy was explained that he would receive 25 cents for every bowel movement in the toilet, 10 cents for every time he urinated appropriately in the commode, and 10 cents every morning that his bed was not wet. And the parents have to give the reinforcers directly after the desired behavior occurs. They have to praise the child, ignore all inappropriate bowel and bladder movement, and change his clothes as functionally as possible, and prompt their son and give him 5 cents for just trying to go kaka. So at first, the instructions were frequently violated by the parents during the early phases, but then this program was carried out for 12 weeks when it became apparent that while the boy's urinatic problem was responding satisfactorily, but the same could not be said for the soiling. So as for the results, the boy got his reward for not bedwetting until week 11, but then after the treatment week, he bedwet for 4 times. A dramatic improvement in the rates of bladder movement in the toilet and a consequent decline in pants wetting also occurred. And then from a baseline of 0 for toilet use, the rate shot up to 45 in week 3 and 35 in week 4. And the total number of appropriate urinations varied widely from week to week. As you can see in the graph, the baseline phase in first and second week showed 0 toilet use, and then increased to 7 times, and 13 times of soiling decreased to 10 times. During the treatment week also, the boy saw 40 times, and the use of toilet is 22 occasions, with a peak significant number of soiling in week 5. Furthermore, the number of toilet used during week 4, 8, 9, and 11 were higher than the number of the soiling. After the treatment week, there were 76 appropriate bowel movement and only 3 incidents. And the highest number of toilet use were in week 14 and 15 before it decreased again until week 10 with twice soiling incidents. So the frequency of trying to go kaka rewards dropped to almost 0 within 5 weeks. In summation, the results show that a straightforward operant method can be administered successfully by the parents. 2 years after that, the monetary rewards have been faded into a weekly allowance, and the number of praising interactions between parents and child multiply considerably. That's all. Thank you.
We move to another article about treatment of encopresis in a classroom setting, a case study by Elizabeth Escott. So encopresis or fecal incontinence is a lack of bowel control. This Souza said that etiology is varied and may be related to the toilet training habits, parent and family orientation and experience, low intelligence of the child, age, poverty and large families, psychologically related conflicts, stress, insecurity and overprotection, regression and anal fixation, the expression of aggression or resentment and attention-seeking behavior. So the subject of the study was a severely deprived 8-year-old boy of limited intelligence who differentiated inappropriately. The child had always been totally incorporated, anoretic, despite the efforts of the professional services who helped the family. Medical examination revealed that there was no organic cause for the problem. So there are 2 factors lead to the decision to carry out the program within a classroom, which is first, according to mother, The child was not incorporated at home, so the validity of this statement was overheld to the downfall. 2. The teacher's negative attitudes towards the child had increased to the point where she was becoming quite disturbed by the unpleasantness of the situation and frustrated in the time spent coping with the problem. So in this story, David was brought to the attention of the child guidance service when he was 7 years old. This is because his behavior was disruptive, his ability to cope with the early learning activities was deficient, and Encopresis was his problem. While his IQ was within 65 to 70 range and he was transferred to special school, where his behavior was brought under control. He was able to cope with the learning tasks, but his Encopresis showed no signs of improving. While David's background also was one of several deprivation because of mother's limited intelligence and apparent inability to look after the child, the social work department assumed the responsibility of removing her child from her at birth. Most of her child had therefore been fostered in infancy, though she had been allowed to keep 2 children, which is David and an infant of 12 months. The level of deprivation in the family was high, so the social work department was actively involved in supporting them. David also had been toilet trained for blender activity at 3 years, and there was no problem of enuresis. He was a deprived child who craved for attention, and he also believed that this was a causative factor in his Encopresis. So, in week 1 to week 3, this is the first phase of this program involved establish a baseline for weekly soiling and appropriate use of the toilet. The frequency of soiling in 1 week was high. You can see that. David arrived at school each morning, having soiled himself on the bus when he wanted to go to the school. He soiled on average 10 to 12 times a week, usually after meals. The teacher responded to this by taking him to the toilet, cleaning him and changing his clothes. In week 4 to week 7, teaching is control. The time spent by the teacher in coping with the problem was reorganized so that her attention could be channeled appropriately. In their first attempt, the teacher herself manipulated the reinforcement and contingency for appropriate behaviors. At intervals of 1 hour, the teacher removed the child to the toilet. Cleanliness or correct evacuation was paired with social approval and praise. Soiling was paired with social disapproval and a show of anger. During this period, no significant improvement occurred. Observation from the teacher's behavior revealed the probable reasons for this failure, which is number 1. Because of the unpleasant experience of having to handle the problem for so long previous to the setting up of his program, she was unable to act in a discriminating way. In both the positive reinforcing and punishing situation, both modulation and attitudes toward the child were noticeably similar. In both situations, David was receiving the same amount of attention and was unable to discriminate the positive from the punishing attitudes. So from week 7 to week 15, in their second attempt at coping with the problem, they introduced a full-time nursery nurse as their reinforcing agent. She was taught the use of differential reinforcement paired with a time-out contingency as a mild punishment, and this left the teacher free to respond to David in relation to his classroom activity only. So, the program was designed as follows. In nursery nurse, we met David at 1 hourly interval in the classroom beginning at 9 a.m. when David first arrived at school. Then he was taken to the toilet. Cleanliness or correct evacuation was again paired with social approval and praise, but he was also taken to a special room catered for him. The nursery nurse reinforced David verbally for his cleanliness, played with him and giving him her full-time attention. This session lasted approximately 30 minutes. The nursery nurse also encouraged David to stick stars on a prepared poster for clean behavior. If David saw himself between sessions, the nursery nurse punished him by telling him he must clean himself. She then walked away, leaving him to care for himself and refusing to remove him for this reward session. This reaction by the nursery nurse made a deep impression on the child, and his esteem and cooperative behavior ceased almost immediately. The interval between sessions extended from 1 hour to after meal time only. This proved more difficult for David in week 12, though his level of responding remained much higher compared to the baseline. So, the nursery nurse gradually decreased the length of time she spent with David, first to 20 minutes, then to 10 minutes. You can see in week 13, and then in the final stage in weeks 14 and 15, the nursery nurse did not remove the child from the class but reinforced him within the classroom. To week 16 to 18, the necessariness was withdrawn from the classroom and the teacher at this step was able to take over the control from the necessariness. So we can see the teacher in control in here and the encopresis is almost ceased immediately. So last of this case study, the result of this case study indicate that the combined procedure of verbal instruction and reinforced sampling was effective in rapidly increasing the appropriate toileting behavior of the child. This appear to be two characteristics of the child which seem to be prerequisite to the success of this type of treatment. First, all the toileting components will be in their basic behavior repertory. Two, he had sufficient verbal competence to circumvent the necessity of shaping behavior and delivering reinforcement immediately after a response. So we will continue with my friends.
Hello and Assalamualaikum. I am Izziani binti Zaki, Mexican with A164002, and I'm here today to present about Encopresis and the article titled with Toilet Training, Queuing, Praise and Self-Cleaning in the Treatment of Classroom Encopresis, a case study by Joe W. Dixon and Richard A. Saudargas. For introduction, the study was designed to ameliorate encopresis in 6-year-old male child in the school setting, and the procedure consists of toilet training, queuing, praise, and self-cleaning. Prior to interventions, encopresis was a daily event at homes and school, and the intervention was successful in reducing swelling to near zero at school with no reported changes at home. Implications discussed for school psychologists were: first, handling the intervention through a consultation model, using the simplest approach before attempting more powerful procedures, attempting treatments in spite of the fact that other treatments attempts at homes had been unsuccessful. And for the method, the subject was 6-year-old white male child beginning first grade named Tommy. He was of average intellectual ability with mild signs of emotional disturbance, according to current records which included an yearly psychological report. He has an 11-year-old sister with no history of enuresis or encopresis, and he lives at home with his sister and both parents. Enuresis means involuntary urination, especially by children at night. It caused by a variety of factors. This includes disorder of kidney, bladders, ureter, and poor control of the muscle that control the release of urine. While for the settings, the study took place in a rural grade school in Eastern Tennessee, and the class had approximately 25 children ranging in age 6 to 8 years old. There was one experienced regular classroom teacher, and during the studies, a student teacher aide began working in the classroom. However, the aide did not become directly involved with the study. Throughout the study, Tommy was enrolled in a resource classroom for 1 hour a day, in which he received extra assistance in arithmetic and reading skills. Otherwise, Tommy participated in all regular classroom and school activities. Next is procedure, and for the procedure, there are 3 procedures in the study, which is baseline, phase 1, and phase 2. For the baseline, the teacher recorded soiling episode during the first week of school, and the data were collected weekly by senior author. When Tommy indicates he had soil, the teacher clean him up, assist him in putting on clean clothes brought daily from home. And the teacher also told him that she did not approve of his behavior and asked him to stop. The next stage is phase 1. On this phase, there was a conference which followed by the classroom teacher, special education teacher, mother, school principal, and also the senior author. During this conference, the teacher classroom was given instruction in toilet training procedure, which is similar to Fox and Ezrin's 1973 procedures. The teacher trained Tommy once an hour while until he reached 100% criteria, which occurred in third training session. This was done to make certain that he had the correct toileting behavior in his repertoire, which is on his first day of phase 1. It is also consists of establishing prearranged cue, eye contact and head nod. He then was taken to the bathrooms and probed throughout the process of pulling down his pants, sitting upon the toilet and remaining there for at least 2 minutes, correctly using toilet paper if there's no bowel movements, pulling up his pants and flushing the toilets. Then, after he returned to his seats, the teacher quietly gave him a verbal praise. And for the phase 2, Tommy was given the toilet training procedures, but only once on the first day of the condition. The cueing, verbal prompts, and verbal praise procedures are also were discontinued. However, Tommy would still have to clean himself and change his clothes without assistance, and he was subject to the same teacher consequences for rule violations as the rest of the class. The classroom teacher reported toward the end of phase 1 that Tommy was beginning to violate classrooms rules with increasing frequency since there was no consequences for him. In essence, beginning with phase 2, Tommy was treated exactly like the other children and received no special attention. As the results, when phase 1 begins, the soiling episode fell to 0 and remained there for 9 consecutive days. During phase 1, Tommy soiled himself on 8 of the 13 days, or 37% of the time, as compared with baselines, which was 100% of the time. In phase 2, prior to Christmas vacations, there were only 2 days in which soiling occurred: school days 43 and 44. This incident coincides with a change in Tommy's my special education teacher due to scheduling changes within the school. Following school days at 18th, school dismissed for Christmas vacations. Upon returning to schools, Tommy saw himself the first day back and once the following week after an absence the previous day. After that day, there were no more spoiling episodes for Tommy in school. As we can see in figure 1 on the result and on the graph, based on the graph on school days 16, 20 and 32, Tommy's mother visited the school unannounced. And lastly, for discussion, the methods were clearly effective in ameliorating the classroom Encopresis, and the teacher reported that the time necessary to train approximately 5 minutes per session and monitor Tommy was minimal and was not disruptive to the regular classroom. Both the classroom teacher and the special education teacher reported a marked improvement. There are also 3 issues for the preceding school psychologist which this studies exemplifies. The first is the minimal time involvement for the school psychologist in handling the problems within a consultation framework, while the second issue is principle of attempting a simple solutions to a problem before beginning with more complex and powerful procedures. The third issue is that of proceeding with interventions in school with problem of seemingly complex etiology. There may have been problems with the relationship between Tommy and his parents, of which the Encopresis at home was part. However, the data indicated that the home situation did not preclude a successful school interventions. That's all from us for Encopresis. Thank you.
So let's forward to the next topic, which is about attention deficit hyperactivity disorder. The first article is about evidence-based treatment of attention deficit hyperactivity disorder in a preschool age child, a case study. So for the introduction, ADHD is a neurobehavioral disorder characterized by core symptoms of inattentiveness, distractibility, hyperactivity, and impulsivity that are noticeably greater than expected for their age and cause distress and problems functioning at home, at school, or with friends. ADHD is thought to be the most common childhood mental health disorder. So ADHD is diagnosed as one of 3 types, which is an inattentive type, hyperactive type, or combined type. Among psychosocial treatment for ADHD, behavioral approaches have the best empirical support, which include parent training, PT, contingency management, CM, and school-based approaches such as the daily report card, DRC. So the subject name is Peter B, and he was 4 years 1 month old at his initial evaluation and was attending his second year of preschool by this time. Peter has no siblings and live only with his mother, and Peter has no significant medical history and no developmental concerns apart from behavioral symptom. Detail next. Peter was assigned a special education itinerant teacher SEIT by the Board of Education because of aggressive and disruptive classroom behavior. So next is methodology. In this case, there were 4 treatment total. Started with pre-treatment, which is assessment and diagnosis. So Peter came for interview administered by a clinician from New York University Child Study Center NYUSC with his mother about kiddies scheduled for affective disorder and schizophrenia to assess mental disorder. Miss B also attended the same interview as Peter and also answered a parent and teacher completed questionnaires. Miss B also completed the SNAP 4 and completed the IBEC Childhood Behavior Inventory and Child Behavior Checklist. The teachers also had a phone call interview and completed Child Behavior Checklist. SEIT also completed the SNAP 4 and teachers and Miss B answered parent and teacher completed questionnaires. These data were used to clarify the diagnostic picture, identify treatment goals, and assess progress. Peter met diagnostic criteria for ADHD, combined type and ODD, and began his treatment 9 weeks after his evaluation. ODD is a disruptive behavior disorder in children and teenagers, characterized by patterns of unruly and argumentative behavior and hostile attitudes toward authority figures. The SNAP was given again to provide a second baseline measures of Peter's symptoms. So for the first treatment phase is Parent-Children Interaction Therapy, PCIT. Peter and his mother attended 10 weekly sessions of PCIT. So at first, Miss B learned about CDI at the first session, and her skills had been coached and was assessed with Peter in the next session. And after that, Miss B practiced it. CDI teach parents to differentially attend to appropriate behavior and ignore disruptive, non-dangerous behavior in the context of play. And after that, Miss B was trained in PDI, involved use of command and contingent consequences. Then, Peter still observed a session and began actively participating after Miss B reached PDI mastery, requiring only 3 sessions. The seed, however, mastered PDI, but then she not reached CDI mastery, maybe resulted from her abbreviated training and her observation of PDI only. For the second treatment phase is school-based behavior management. Teachers, SID, and therapists met in week 20 to develop a classroom behavior program. A behavior plan was created based on the functional analysis of the sum observation, antecedent, and consequences to disruptive behavior, and a brief functional analysis was conducted to Peter. Peter therapists and SID participated in 6 bi-weekly coaching sessions at Peter's school. Coaching was conducted via bug in the ear, which the SID was guided in structuring behavior with effective comments and positive attention by the therapist. Stationed 15 to 25 feet away so as not disrupt the students during coaching. All the equipment provided by the therapist. Peter's teachers were taught selective attending, active ignoring, and principles of effective comment. 1 hour monitoring periods were proposed for 4 behavioral targets stated in the schedule below. Okay. Stickers serve as a secondary reward and a means of tracking compliance. In school and at home rewards were to back up these DRC points. Peter's teacher then requested that monitoring periods match the 3 school periods to fit existing class rules, which are before lunch, after center activities, and before dismissal. The complete DRC was photocopied, filed, and sent home each day. Peter earned a special activity at school, such as walk or game, if he earned 6 of 8 possible points by the end of period 2. If he earned 9 of 12 total daily points, Peter could choose an at-home reward, such as small toy or special dessert, from a menu developed by himself, his therapist, and his mother. Peter's principal requested that punishment be introduced only if these initial methods prove insufficient, and unfortunately, this happened in week 23. So the therapist suggested use of DO, which would provide an evasive consequences for disruptive or defiant behavior by temporarily limiting access to attention, items, or activities. DO would have been contraindicated whenever Peter escaped any activities or demands, broke standing rules, or non-compliant after a warning. as it would have negatively reinforced disruptive behavior. TO was to be taken on a chair in the hallway outside of the classroom and to be 3 minutes in duration. TO non-compliance would result in longer duration as TO not start until Peter was sitting in the chair. For TO to end, Peter would be required to comply with the initial command or agree to comply with the rule he had broken. A viable backup TO was clearly necessary as Peter was not showing a really good attitude. They prescribed a TO room, but Peter's school had no such room, so the alternative exploit was a reinforcement course TO backup to Peter's DRC, which had been added by Peter therapists at the end of week 25. The point were awarded if no TO was given in a period. If TO was given but taken appropriately in a period 1, point was awarded for that period. HTO not taken appropriately will subtract 1 point DRC response course. The therapist then proposed brief therapeutic holds as a TO backup as he hit or ran the staff. Peter would be held for 30 seconds, then redirected to TO. If he left the TO chair, he was held again and so on until he had complied with a full, uninterrupted TO. TO was served in the stairwell instead of the hallway, allowing staff to ignore yelling. Peter's therapist provided coaching in these methods, which were implemented in week 27. And for the last treatment phase is assessing gain, which is in week 34, treatment session 17. Miss B completed the tracking sheets and continued to use CDI and PDI skills daily to address non-compliant disruptive behavior. So for the pre-treatment result, Peter snapped 4 scores from his initial evaluation completed by his mother and state are presented in table 1, baseline 1, which according to the evaluation, Peter's mother and teachers' primary concerns were his non-compliance, impulsivity, hyperactivity, reactive aggression, and difficulty concentrating. Peter met diagnostic criteria for ADHD, combined type, and ODD after his interviews at NYUSC. He began his treatment 9 weeks after his evaluation. The second SNAP evaluation given to measure Peter's symptoms is provided in table 1, baseline 2. The results for treatment phase 1. By the third session after his mother's CDI training skills, Peter quickly engaged in positive behavior when his mother ignored disruptive behavior. Peter also enjoyed prescribed daily playtime very much and he thanked his mother for praising him. For the more during PDI sessions, compliance with command increased and TO decreased. His mother reported similar gains between sessions, giving fewer TO per week by the end of PCIT. So the result for second treatment phase, Peter initially responded well to the RC system, receiving enough DRC points to earn rewards on 4 of the first 5 days. However, by end of week 22, Peter's early gains had diminished. His defense, impulsivity, and aggression often increased when he was redirected by teachers or when his play was disrupted by a peer. So in week 23, Peter's principal agreed to add negative consequences to his behavior plan. Introduction of TO in week 23 corresponded to an increase in average DRC points by week 24. However, Peter occasionally ran, hit, or spit when given TO, which consequently lasted for 30 minutes or more at times. When he did sit, his yelling was disruptive to multiple classrooms, and because of that, a TO backup had been made. This yielded increased DRC points and TO compliance the first day, but thereafter Peter was again non-compliant with TO, losing many points and appearing less motivated by DRC rewards. His said surmised that taking TO was more aversive than point loss. By week 26, TO had increased markedly and DRC points had fallen. It appeared that this TO backup was not only ineffective but was also compromising the positive, if sporadic, initial DRC effects. Nearly immediately, Peter's behavior and verbalization indicated that he found TO less aversive than TO backup holds. So by week 29, Peter was compliant with most TO. His DRC points had increased, and running, yelling, and hitting during TO had been nearly extinguished. By week 31, TO had decreased and the RC point had further increased. The treatment phase 3 result in week 34, Ms. B reported decreased disruptive behavior at home and found Peter required TO and other punishments less than once per week, a 5-fold decrease from early PDI. Marked improvement in focus and attention but less change in hyperactivity, which nevertheless caused little impairment because of her ability to redirect Peter effectively. And DC also reported a substantial increase in the RC points and infrequent TO, reduced defiance and aggression. Peers no longer avoided him, instead including him in their play. As noted in Table 1, her reports regarding ADHD symptoms were less consistent. SNAP hyperactivity, impulsivity, and inattention scores fell to subclinical levels, but the child behavior checklist indicated attention problems remaining in the clinical range. Peter said and teachers anecdotally reported continued impairment from hyperactivity in attention and presented ADHD symptoms inconsistently, being present at times and absent at others. And finally, for the discussion, although Peter's treatment was informed by EBT principles, some limitations that were also related to the degree of involvement Peter's mother and teachers are not worthy. Because of this limitation, Peter's actual treatment progress is difficult to unambiguously evaluate. Clinical judgment and careful consideration of treatment data were therefore needed to determine whether these interventions were beneficial, ineffective, or even counterproductive. This ongoing process, aided by the dedicated involvement of Peter's mother and teachers, yielded a treatment that was informed by research-supported principles and techniques, yet tailored to Peter and his environment, essential qualities of evidence-based practice. That's all. Thank you.
To the next article, improving the effectiveness of behavioral classroom intervention for attention deficit or hyperactivity disorder, a case study by Gregory and William. So in practice, classroom-based treatment for ADHD include behavior modification procedure and stimulant medication. The combination of these two treatments often be necessary to normalize functioning. And research has suggested that nearly all teachers report using some form of behavior modification in their classroom because they are commonly report using evidence-based behavior modification technique. The serious impairment experienced by children with ADHD and associated costs in school settings seem puzzling. So there's a number of factors may result in discrepancy, which is typical classroom intervention used by teachers may be of insufficient intensity to result in clinically meaningful improvement for a child with ADHD. Compounding the problem is that although many teachers may be familiar with behavioral interventions in the classroom, many may not receive sufficient training in behavior modification. So as a result, even though teachers and other school staff members may plan to implement a behavioral intervention in the classroom or report doing so, the actual behavior program a teacher implements may not be effective. In this case study, John was an 8-year, 11-month African-American boy in a general education third-grade classroom, and he was diagnosed with ADHD during the first half of the school year when his pediatrician using a parent-teacher and parent-teacher scale and the Committee on Special Education classified as other had impaired and developed an individual education program that include a small group instruction in reading and maths with special education teachers, speech class once a week, and the provision of a daily behavior sheet with an opportunity to earn weekly or bi-weekly classroom-based reward. And John was not medicated with stimulant medication. And the teacher described his impairing behavior such as producing for academic work and also always interrupting teachers or getting out always sick without permission, and other children did not want to sit near or work with John, and the teachers often became frustrated with his classroom disruption. Academically, he was capable in many activities, but because he was often off task, he failed to follow instruction on assignments or did not complete his work. So this is the intervention by teacher which they using daily behavior sheet that targeted 5 posted classroom roles, which is finish work in the time provided, follow directions, work quietly, cooperate with peers and above, stay on task. But in this time, John had yet to earn a reward. Even though they offer an even bigger reward, nothing motivated John. There are two with each observation and consumer satisfaction. In observation, John and comparison child were outside twice a day for 50 minutes, once in the morning and after lunch. During observation, a child was coded as disruptive if he or she destroyed property, talked back to an adult, disappeared, and etc. A child was coded on task if he or she was attending to the ongoing activity. During the observation period, the observer watched the target child and the same set of comparison child simultaneously. And during 50-second interval, the observer recorded whether any disruptive behavior occurred during the interval. And after each 50-second period, a 6-second record period occurred during which the observer watched the target and comparison children for 1 second and assessed and recorded on task behavior. In consumer satisfaction is an important index of the social validity of the treatment. So the teacher who implemented the intervention will ask to complete a writing scale that asks about their satisfaction with the consultation, intervention and outcome of treatment. To the procedures. First, the consultant suggested placing the latency to reward for John. Given that he had yet to experience a reinforced positive behavior, it was hypothesized that frequent and consistent rewards might improve his behavior. They reported that John enjoyed playing his handheld computer game, and when asked, John reported that he would like to end computer game time during lunch and before his meal. The intervention initially targeted just afternoon behavior only, but because of the success of this afternoon intervention, it was eventually modified to provide an opportunity to play his handheld computer game in the morning and afternoon. Second, some teachers had not provided feedback his progress towards his daily behavior goals until after each class was over, and he often spent long period of time of tasks of engaging in disruptive behavior before teacher intervened. And John also typically responded to teacher feedback about his inappropriate behavior by exhibiting on task and appropriate behavior. Thus, feedback to John regarding his negative behavior was an effective consequence, and he received immediate feedback whenever he began to exhibit a behavior incompatible with his behavior goal, operationalizing just behavior targets, modify an antecedent of his behavior because he now knew exactly how many rule violations resulted in his failure to earn the reinforced, in contrast to the prior approval of him and his teacher arriving at a consensus about whether he met his goal. So during the baseline, John Fisher continued to use the system of weekly rewards and he earned no rewards during the phase. The use of his handheld computer game during this system was non-contingent. So during the intervention condition, Sean teacher placed a check mark on his daily behavior sheet if he earned his daily reinforcer, and just was not allowed access to the computer game unless he met the operationalized behavioral expectation. To ensure that John did not have access to his computer game unless he earned it, his teacher kept it in her desk except for the times John earned his reward. So there are three major changes were made to the teacher's current behavior modification program. Number one, John was afforded the opportunity to earn daily rewards based on his classroom behavior. Two, teacher were asked to provide immediate feedback to John when he violated classroom rules. Three, the behavioral criteria on John's scholarship were operationalized at fewer than 3 violations of each classroom rule. To the results. In figure 1 is display the percentage of interval shown as exhibited disruptive behavior during baseline intervention condition. You can see the top panel represents afternoon behavior and the bottom panel represents morning behavior. As the graph indicated, baseline behavior in the morning and afternoons was variable, and one effect of the intervention was to decrease the variability. In the afternoon, the percentage of intervals in which John exhibited disruptive behavior before the intervention was 29.86%. After the modification were made to his behavioral programs, the percentage of his behavior program, the percentage of disruptive behavior After the modification were made to his behavioral program, the percentage of disruptive behavior intervals decreased to 10.33%. And in the morning, the percentage of the percentage of intervals John exhibited disruptive behavior was 21%, and the intervention resulted in decrease to 7.50%. And this figure 1 displays the percentage of intervals John displayed on task behavior during baseline and treatment phase as the same as the figure 1. The top panel represents afternoon behavior and the bottom panel represents morning behavior. So in the afternoon, before the modification were made to his behavior program, John's percentage of intervals in which his exhibited on task behavior was 62.14%. On task behavior increased to 84.33% after the intervention, which was within one standard deviation of the classroom. In the morning, the percentage of intervals in which John exhibited on task behavior improved from an initial rate of 66.78% to 92% after the introduction of the intervention. The result from consumer satisfaction revealed that they strongly agree with the items and were highly satisfied with all aspects of the treatment and its outcome. In our discussion of this case study, a clinical implication, the modification of increasing the opportunity to earn the rewards and operationally defining the criteria John needed to meet for behavior goals, coupled with increasing the immediacy of the feedback he received regarding his behavior, substantially increased the effectiveness of the classroom behavioral program. This relatively minor modification resulted in such an improvement that his behavior improved to within the monthly rate of functioning. So this modification were obtained by increasing the intensity of behavior modification program, and John's behavior were normalized relative to classroom peers without adjunctive stimulant medication. And also the teachers were highly satisfied with the consultation and intervention procedure. So overall, this result illustrates how behavioral procedure with demonstrated efficacy in research or analog setting can be used effectively in a general education setting. So in a research application in this case study, the classroom norms provided an excellent standard against which to compare treatment effects because the percentage of disruptive and on-task behavior varied across settings and the child improved to within classroom norms in both settings. So it appears that classroom norms are an important indicator of treatment outcome, and because classroom vary in terms of structure, activity and teachers' tolerance for inappropriate behavior and decision on clinical outcomes should be based on individualized classroom norms specific to each activity or setting of interest. So there are also a limitation in the study, which is a major limitation of this investigations that only two baseline were used in the study. The data collection period for the second intervention period was relatively brief. Another limitation of this case study is that no follow-up data available, and the utility of the approach is limited to teachers who just currently have a classroom behavioral intervention established. So the last article about ADHD, I will give it to my friends.
The next article is about behavior management for school-age children with ADHD by Linda J. Griffin and Lauren M. Z. Introductions. Behavior management treatments are well-established, evidence-based treatment for school-age children with attention deficit hyperactivity ADHD disorder, ADHD, and should be widely recommended to families. School-age children with attention deficit hyperactivity disorder or ADHD shows a range of inattentive hyperactivity and impulsivity symptoms that translate into serious academic and social or interpersonal impairment at home, school, and in other settings as well. For example, public places, sporting events, and camps. Behavioral parent training can be augmented with classroom-based interventions or child's component to extend results across home, school, and social settings. Common problems targeted for behavior management treatment at home may include non-compliance and lack of independence in completing daily chores and routine. For example, getting ready in the morning and going to bed at the established time. Homework problems such as unrecorded assignments, forgotten materials, need for frequent reminders to start and complete homework, disorganizations, and lack of attention to detail or careless mistakes. Third, co-occurring aggression and defiance towards parents or siblings. For the method, there are three methods, which is functional behavioral analysis, parent-child interaction alterations, and evidence-based treatment validations. For the functional behavioral analysis, the first step is in designing a behavior management intervention involves conducting a functional behavior analysis, which includes identifying targets behavior to increase positive behavior or decrease negative behavior, and then identifying factors in the child's environment related to the occurrence of the target behavior. Specifically, factors in the child's environment occurring immediately before and after the behavior that may be precipitating or maintaining the likelihood of the behavior are identified. In this way, the function of the behavior can be determined, for example, to get attention or avoid work. Target behavior typically represents area of functional impairment affecting the child in their everyday life and sometimes, but not always, map directly onto the symptom of ADHD defined in the Diagnostic and Statistical Manual of Mental Disorders. Behaviors as well as the antecedents and consequences are defined so as to be objective and measurable. Based on this analysis, as behavior plan can be developed that changes and the antecedent and consequences that have been maintaining the target behavior, thereby modifying the likelihood of the behavior in the desired directions as increase positive behavior and reduce negative behavior. Next, the second method is parent-child interaction alterations. In addition to using functional behavior analysis, behavior management treatment focuses specifically on altering negative parent-child interactions factors, which are often present in the families with a child with problem behavior, including ADHD. These interaction patterns, referred to as the coercive process, are cycles in which parents and children controls one another's behavior via negative reinforcement. An example of the process occurs when children show problem behaviors and parents respond negatively, creating a cycle, each time escalating in severity or emotional tones. Either the child or parents complies with the other's demands, ending the cycle and reinforcing the escalated negative behavior patterns. The third is the evidence-based treatment validations. BPT, known as behavioral parents training, has been confirmed as well as established treatments based on straight evidence-based treatment. EBT, evaluation criteria for evaluating psychosocial treatments in 3 separate reviews in 1998. Combined behavioral treatment, which at schools or child component to BPT, also meet criteria as well as established treatment based on the most recent review. Furthermore, numerous studies of BPT alone and combined with other behavioral treatment with evidence criteria based on what works Clearinghouse Standard Institute of Education Science and are categorized as type 1 and 2 control studies that use rigorous scientific methodology using Nathan and Gorman categorization criteria. Outcome from these studies include improvement in child compliance, conduct problems, and parenting as measured through blinded observation and ratings, and improvements in parent-rated ADHD. And also oppositional defiance disorder symptom, disruptive and aggressive behaviors, homework problems, and overall functional impairments compared with alternative treatment, wait list or usual care controls, reduce parenting stress, and increase parenting self-confidence are also reported. Next is procedure. How is the treatment delivered? BPT behavioral parent training usually includes 8 to 12 groups or individual sessions and focus on 3 main objectives. First, providing psychoeducation about ADHD and the behavioral framework for treatment. Second, teaching effective parenting skills to improve desired behavior and decrease the problem behavior by altering the antecedent and consequences. Third is practicing or troubleshooting effective implementation of such skills. To accomplish these goals, each session usually structured to include a didactic portion in which new materials is presented, as well as an interactive portion in which parents discuss the implementation of parenting skills, including teacher involvement, peer involvement, non-traditional caregiver adaptations, specific child problems, and improved accessibility. For the parenting skills, most BBT programs begin with teaching parents positive attending skills to improve the parent-child relationships. Second, to promote a positive climate as well as contingent positive consequences such as praise, activity rewards, token economics, or point systems. This is to encourage appropriate child behavior. In addition, parents often find it easier to implement reward rather than punishment programs. Emphasize setting stage for child compliance and independence by teaching parents to provide clear and specific comments, to establish consistent routines and expectations, and to implement when the contingency system. For example, when the child complete their homework, then he or she can have their screen time. Next is teacher involvement. Teacher involvement BPT can be expanded to include an adjunctive empirically supported behavior intervention to address a broader range of problem behavior and enhance generalization of treatment gains across settings. Many BPT programs at school-based interventions such as early report card. The RCs are individually designed for each child and include target problem behavior in academic or social domains. Teacher provide a rating for each target behavior on the DRC, which is sent home daily, and the child is provided with home-based reward based on the rating at schools. Next, for the peer involvement, BPT has been combined with child treatment, including behavioral peer interventions. This treatment generally focuses on improving social interactions or study or organizational skills. For example, Prifne and College combine BPT and school consultation with a child training in executive and social interaction skills in an integrated program for the inattentive presentation of ADHD, Child Life and Attention Skills class programs. For non-traditional caregiver adaptations, BPT has been adapted for use with caregiver population underrepresented or less responsive to traditional programs such as single mother, depressed mother, and fathers. This treatment largely follows the structure and topic described. Next is specific child problems. BPT has also been tailored to specific child profiles and problems. For example, McCamey and colleagues modifies the scope of BPT to target friendship, a commonly associated impairment domain for children with ADHD. This treatment, called parental friendship coaching, teach parents strategies for encouraging and reinforcing their children in the practice of successful peer interactions. Treatment involves training parents and teachers to reinforce children continuously for meeting endpoint targets, goals for improving organizational, work and school performance, and included a DRC, token economy for achieving home goals and homework rules and structures. Improve accessibility. Recent efforts have been made to improve accessibility and feasibility of behavior management interventions by delivering treatment via convenient, trusted, and cost-effective environments and modalities. For example, a more practical alternative to clinic-based BPT has been developed relying on handbooks, videos, and weekly telephone sessions for intervention delivery. As the results, there are benefits of therapy adaptations. The recent adaptation of BPT to reach fathers, single mothers, and depressed mothers all show benefit in terms of better engaging the families in treatment, and further involvement may enhance treatment maintenance. Adding cognitive behavioral treatment of maternal depression to BPT results in additional reduction in maternal depressive symptoms. And lastly, for discussion, behavior management treatment in the form of BPT for school-aged children with ADHD are well established. ABTs meeting rigorous criteria for level 1 in the level of evidence framework specified by the Oxford Center for Evidence-Based Medicine guidelines. This approach can be combined with empirically supported school-based and child treatments to enhance potencies and generalization of effects. Continued research is needed to better tailor treatment to families with multiple stresses, parent mental health concerns, for example ADHD or depressions, and those from varied family structures and cultures. That's all from us. Thank you.